And Ken, I am not seeing Dan on yet. So if you can do the welcome for us, that would be terrific.
Welcome, everybody. As you know, Ask the Expert is our opportunity to bring the best thinkers, the best researchers, the best clinicians, and leading peers to you. And we're interested in your feedback and input. I want to let you know next month in December, Gail Daumet of Johns Hopkins University will be reviewing the literature on reducing your cardiovascular and metabolic risk. She's well published in the New England Journal of Medicine. And again, in this time of COVID, we wanted to make sure that we made the opportunity available to review the literature on how you can take care of your lungs and how you can take care of your heart. And on the smoking front, which is today's topic, it's an absolute pleasure to introduce Dr. Eden Evins. I was incredibly fortunate to see her as a brilliant resident at the Massachusetts Mental Health Center, and I knew she had great things ahead of her. She went on to found the Center for Addiction Medicine at Mass General Hospital and became a full professor of addiction medicine at Harvard School of Medicine, and the Cox family funds her professorship. Eden also had, in her spare time, picked up a master's in public health. What I like about Eden are many things, but her ability to help people think about how to think about quitting smoking and what are the evidence-based strategies to do so. And she attends to people's symptoms. And she does a lot of work to make sure that people know that you can quit smoking and do quite well with your symptoms. So Dr. Eden Evins, I want to thank you for donating your time to NAMI. We're incredibly grateful for the research and work you're doing and for giving us your time today. So why don't you take it away and put the questions in. I'll rejoin after Dr. Evins has done her presentation. Thanks, everybody.
Fantastic. Thank you, Ken. Can you hear me?
Can hear you great.
So I want to put a plug in for Gail Daumet for next month. She's a friend and a collaborator. We're doing our third study together because, of course, smoking cessation is one of the best things you can do to improve your cardiovascular health. So tune in to see Gail.
And that is December the 10th. Dr. Daumet will be doing this Ask the Expert. So thank you, Eden.
That's great. So I bring good news, and that's really fun. The good news for people who smoke, how people with and without serious mental illness can quit smoking. There's lots of new good stuff out there. So next slide, or first slide really. So the main thing is that people with serious mental illness who take a medication to smoke do not get more adverse events. They do not have more depression, anxiety, hallucinations. They do have more, sometimes more trouble sleeping, and that's across the board. And we know that from this study. And if you look, this was the EAGLES trial, which is the EAGLES stands for down the bottom. You can see evaluating adverse events in a global smoking cessation study. This was an FDA-required clinical trial to evaluate the safety, the neuropsychiatric safety of propion in over 8,000 members with and without a psychiatric illness. So we had 4,000 people with a psychiatric illness, either a psychotic, an anxiety, or a mood disorder, and 8,000 people without. And this was at 144 sites around the world. And what you see in the first series of bars, this is the rate of adverse events amongst people without a psychiatric illness. The blue bar is varenicline, 1.3%. The green bar is bupropion, 2.2%. The purple bar is nicotine patch, which is an active control, 2.5%. And the gray bar is placebo, 2.4%. So if you don't have a psychiatric illness, you have about a 2% chance of having a moderate to severe neuropsychiatric side effect when you try to quit smoking, regardless of what treatment you take, right? You have just as much a chance of having this side effect with placebo as you do with an active medicine. And then if you look in the middle, you see these are the rates of side effects during a smoking cessation attempt. Again, in blue with varenicline, in green with bupropion, purple with nicotine patch, and gray with placebo. So you've got about a 3 times greater chance of having a neuropsychiatric adverse event if you have a psychotic disorder than if you don't have any psychiatric illness. No mystery there. That's over the course of 16 weeks. Many people, or about 6% of people, will have some kind of psychiatric symptom flare up during that time. But it's no different by what treatment you take, and by kind of what. It's exactly the same rate in varenicline, bupropion, and placebo. And then in the far right, in mood disorders, it's the same thing. There's no significant difference across these drugs, including placebo, for people with polar or bipolar disorder who try to quit smoking. And this is the reason why I think safety, people are scared to take a medication to help them quit smoking. And the idea behind doing this, the biggest trial ever in the world for smoking cessation treatment, was to understand, what is that risk? Is that a risk we need to worry about? Because we don't want to see people having exacerbation in their psychiatric symptoms when they try to quit smoking, certainly not due to a medicine that's intended to help people be successful quitting. And lo and behold, we don't see an increased risk in this very large study that was powered to be able to see that. So next slide. So I use this information to talk to not only doctors, but people who smoke and their family members on what's their risk of having a moderate to severe psychiatric adverse event when they try to quit smoking. And it's pretty simple based on this trial. If you don't have any psychiatric illness, your risk is about 2%. If you do have a psychiatric illness, your risk is about 6% of having some kind of transient psychiatric symptom while you try to quit smoking, right? But the key is that rate is not different whether you're on an active treatment that actually improves your chance of success or on a sugar pill, a placebo. Critically, we looked really carefully at this, and there's no pattern of neuropsychiatric adverse events that are the most worrisome. Like, we don't see more irritability or suicidality or say aggressiveness or feelings of hostility. And we don't find any psychiatric subgroup to be particularly at risk. So next slide. What we do see is a major difference across these medicines in efficacy, particularly for people with psychotic illness. So if you look in the middle 4 bars, this is quit rates. Again, blue is for varenicline, 23%. Green is bupropion. Purple is placebo. Purple is nicotine patch, and then gray is placebo at 4%. And this is what we see time and again for people with psychotic illness, so schizophrenia, schizoaffective disorder, is without a medicine, even with the best sort of behavioral treatment, group treatment support, we only see about 4% of people being successful when they try to quit. And trying to quit is hard. And we want to increase people's chances of success the first time they try. And so what we see here is, no matter whether you're in the non-psychiatric cohort, whether you had a psychotic illness or a mood disorder, what we see is the best treatment is varenicline. And in all of those, varenicline or Chantix is significantly superior, statistically significantly superior to bupropion or Wellbutrin and nicotine patch. And there's no difference. And that's been shown time and again. They're about equally effective, and they're better than placebo in every group. So yes, the patch works. Yes, Wellbutrin works compared to placebo. And yes, varenicline works better. And that's true in all of these groups. So the absolute quit rates are different depending on your psychiatric status, but the relative quit rates is the same. And in fact, your odds of quitting are improved more if you have a psychotic illness than if you don't, right? And that's, again, because the placebo quit rate is just so low. And we see that time and again, that people with a psychotic illness really seem to need a medication to sort of replace that nicotine during the time that they are trying to quit. So next slide. So this big study, which is called the EAGLE study, made a huge impact. Basically, what happened was both the FDA and the European Medicines Association, which is essentially the FDA for Europe, removed the box warnings for both bupropion or Wellbutrin and varenicline or Chantix, right? And to me, that was huge, because what I saw is that was going to mean that doctors were going to be less hesitant to prescribe these effective medicines for people with psychiatric illness in particular, and people and their families would be less afraid to use them because this box warning has been removed. And that has the chance to make an enormous difference in people's health and their quality of life and how long they live. Tobacco products are the only consumer product to kill half their users when used as directed. So that's quite a statement. So next slide, please. And this is one of those, so this slide, I think you can see all of these at once. There's no animation here, so I'll just start through with the myths. And the myths are huge. You know, when I first started doing this, people said to me, what, you're going to make your career helping people with schizophrenia quit smoking? They don't even want to quit smoking. And that's not true at all. People with serious mental illness want to quit at the same rate as people without any psychiatric illness. It's 60 to 70% of current smokers with serious mental illness say they want to quit. The next myth is that quitting worsens psychiatric symptoms. And that is super not true. In fact, a really nice paper came out about 3 years ago in the British Medical Journal, a very nice paper, showing that stopping smoking not only doesn't worsen psychiatric symptoms, but within 6 months, quitting smoking improves depressive symptoms, anxiety, and perception of stress in your life with a large effect size that's equivalent to the effect of an effective antidepressant medication. Then the next myth is that meds don't help people with serious mental illness quit smoking. Number one, they're not going to be successful, people think, and so it's not worth any risk. And that couldn't be less true. Like I showed you in the last slide, smokers with serious mental illness are 3 to 6-fold more likely to quit when prescribed a medication. That's 300% to 600% more likely, right? And that's largely because only about 4% quit with behavioral treatment alone. And then this last one is really new information. And it's that a lot of doctors and patients think that meds should only be prescribed for smokers who are ready to quit completely, like right now. And that's not true. And in fact, the official guidance has changed. And that's on the next slide. Okay, so the animation's not working. That's all right. So there are 3 ways to quit smoking, and all start with a smoking cessation medication. And the first is the usual way. There's a fixed quit date. People come in, they say, Doc, I'm ready to quit. Let's set a quit date next week, and we'll start a medicine, and I'll set a quit date next Monday or next Sunday. Usually it's the night before I see him again. And so we prescribe a medication. I explain some of what side effects to think about, to call me if there's any problems, and they keep smoking for that first week while they get ready to quit. And getting ready usually means setting a quit date and planning that day out, maybe sometimes going to a place where smoking is not allowed, like the public library or, you know, the local mall or someplace where it's comfortable and you can do something you like to do, or go to the movies back in the pre-COVID days where you can't smoke. The middle bar shows this new way that the FDA has approved for quitting smoking, and that is you have a flexible quit date. And I usually ask people to set it 5 weeks after starting a medicine, a smoking cessation medicine. So we start the smoking cessation medicine where you see that first green dot, and they take that medicine for a month, and they keep smoking during that time all they want. And the point of that is to get that medicine on board, and they're sure that they tolerate it, that they're not having side effects. So when they set their quit date, when they have some side effects around the time that they quit, we know that those are nicotine withdrawal symptoms. We know it's not caused by the medicine. And this is what I really recommend, and this is what we've used now for, gosh, more than 10 years as our strategies, particularly for people with serious mental illness. Because we meet once a week in that month after they start medicine, and we plan their strategies so that when they do set their quit date and try to quit, they're more likely to be successful. And then we continue the medicine for about 6 months after that time, particularly if they're successful. And then the last one is really the most radical one for the FDA, and what they said is start a smoking cessation medicine for everybody, even people who aren't clear that they're going to be able to set a quit date right away, right? So start the medicine. And the idea is you start the medicine for every smoker. Just like if you've got diabetes, you don't wait for somebody to be willing to change their diet and start an exercise program before you start them on insulin or metformin or some medicine. You do both at the same time. And that really makes a lot of sense to me. And so the idea is that we're trying to get doctors to offer smoking cessation medication to all smokers, and then, work with them to maybe try to cut back a bit. Maybe if they're a pack a day smoker, maybe over that first month, try to cut back to half a pack a day. And then over the next month, maybe try to go down to 5 cigarettes per day. But to do it at the person's pace, which really makes a lot of sense. So to me, this middle one, where some people really do well and they prefer to just set a quit date, especially if you're in a group with other people, you can all set a quit date together and support each other. So some people really prefer that. And then others, just setting a quit date isn't going to work for them, and doing it gradually works. And Gail Dommett and I just finished a big study where we enrolled people who are willing to set a quit date within the first month, and also people who are said that they wanted to quit, but they weren't ready to set a quit date for 6 months. And lo and behold, starting a medicine right away worked for both groups. So next slide, please. So this is really things that you should be expecting from your doc when you go in. You should expect them to ask you each time you go in if you smoke. And people with psychiatric illness have the highest rates of smoking. And then you should expect for them to remind you that quitting smoking is in your power, and it's the number one, it's the single best thing you can do for your health. And in the study that Gail Dommett and I did together, we did exercise and weight loss and diet and smoking cessation, all the things to improve heart health. And in our big study, the thing that really moved heart health or people's risk for having a heart attack was quitting smoking. The rest moved things in the right direction, but it was quitting smoking that made the statistically significant difference in that big study. So you should expect your doctor in this third panel to encourage you to start a medication at every visit, right? So if you aren't ready at one visit, you should expect them to ask you again the next visit. And then to decide together whether you want to set a fixed quit date in a week, or if you want to have a flexible quit date over the next 5 weeks, or if you want if the gradual approach to quitting works for you. And then you should expect a call back within the next week or so from the nurse or the doc, where you can talk about how well you're tolerating the medicine, if you're having any adverse event, and if you are having some problem, where you can problem solve around that. Next slide, please. So there's no difference in dosing these medicines if you do or don't have a major psychiatric illness. For varenicline, it's a 0.5 milligram a day for 3 days, and then a 0.5 milligram twice a day for 4 days, and then it's 1 milligram twice a week for 11 weeks. And then if you've been successful, we recommend another 3 to 9 months of treatment. And in fact, in the study that we're about to publish with Dr. Dommett, we offered people treatment for 18 months. And people continue to quit over the course of that 18 months. And so that's where we think the field is moving. There are no significant drug-drug interactions like with your other psychiatric medications, so it's a really easy medicine to add to the medications that you're on, might be on for your psychiatric illnesses. And nausea and headache are really common. Vivid dreams are also really common. Insomnia does happen for some people, and that's one of the reasons to start the medicine and then wait a few weeks before you actually try to quit smoking, so you see how well you tolerate it. Are you sleeping okay, right? Did you have some nausea, but that's gone away now? And then you're really ready to quit, to set your quit date. So next slide. And this is how-to for nicotine replacement therapy. Now, what we recommend for almost everybody is dual treatment. Dual treatment may even be as good as varenicline. And that means you use the patch, so that's the long-acting version of nicotine replacement therapy. You put a patch on every day. You move it around a different site every day, one arm, the other arm, back, so that your skin doesn't get irritated. And then at the same time, you use either the gum or the lozenge. And that's what you do. Those really help with cravings. It allows you to choose the amount of nicotine, right, that you have in your body at any time. And one of the things that works really well is we ask people when they're trying to cut down or quit that they make a deal with me that when they have a craving, they'll use a piece of gum or a lozenge first. And if they still want to smoke that cigarette after the lozenge or gum is done, okay. But they try the gum or lozenge first, and that works really well for folks because cravings come and go, even though they're very intense when they happen. And a lot of people tell me, hey, doc, the gum doesn't work for me. I've tried it before. And there's one common reason why the gum doesn't work, and that's that it doesn't get absorbed when you have an acidic oral environment. So if your mouth is acidic, and usually that means coffee. So if you're a coffee drinker and you're using nicotine gum, just one swallow of water after your coffee and before you use the gum will return your mouth to sort of what we call a neutral pH, and that will help the nicotine be absorbed. And then the main thing is you don't chew it like gum. The nicotine gum, you bite it a few times just to soften it up, and then you park it between your gum and your cheek. Same thing for the lozenge. Don't chew it up because the whole point is for the nicotine to get absorbed across, the what you call the mucous membranes in your mouth. It won't be absorbed from your stomach. It'll just be digested essentially, and it won't get to your brain as nicotine. So those are the main reasons, because most smokers have tried the gum or the lozenge at some point. So I would encourage you to try again. And I think that might be in 2 slides coming up. So let's look at Wellbutrin on the next slide. So this is just how to take Wellbutrin, and it's just the same as you would bupropion SR is the same as bupropion XL. They're really not different. And so the dosing is 150 milligrams a day for 3 days, and then 150 milligrams twice a day. And I think people tolerate this quite well. The only possible exception is people who feel quite anxious a lot of the time, or have feelings of activation that's uncomfortable, because bupropion or Wellbutrin can make those a little bit worse. On the other hand, if people are taking sedating medicines, the kind of activation you get from bupropion can be kind of helpful sometimes. So a lot of times we'll choose people's meds based on using the side effects to our advantage. And this big square box in this slide is there just to remind you that we've studied these medicines in so many smokers. So there was a meta-analysis, which means an analysis where you pulled together many studies, so of 182 studies and over 70,000 smokers. And just like the Eagles trial, it found that varenicline triples your chances of quitting versus placebo. That's in the general population. And it increases the odds of quitting by 50% over and above NRT and bupropion. So varenicline is 300% better than placebo, or 3 times better, and it's 50% better than NRT or bupropion. So that's really my go-to. It's what I encourage people to try first. And then let's not forget, NRT, nicotine patch and gum, and bupropion or Wellbutrin also nearly double your odds of quitting versus just behavioral treatment alone. So they really work. 80% better chance than placebo is really good, but 300% chance is better, I would say. Next slide, please. So this is really 2 different messages. So if we look at this first graph about how long to treat, this is from a study we did in 256 smokers with schizophrenia or bipolar disorder. This was published in JAMA. And what we had seen is that people on medicine were able to quit, but they fell off a cliff as soon as we stopped their medicine. I just remember that so incredibly. People worked so hard to quit. They would come in our studies, and then within 2 weeks of the study ending, they'd be smoking again. And it's all that work. And so we did a trial where we tried to we gave everybody active medicine, and we tried to get as many people to quit as we could. And then at week 12, which is when, according to the FDA, you're supposed to stop smoking cessation medicines back in the old days, we took all the people who had quit, and we flipped a coin and assigned half to placebo and half to stay on Chantix or varenicline. And what you see here is just what we've seen clinically. When you switched to placebo, you started relapsing. The average time to relapse was 35 days in this group that went on placebo, and the average time to relapse was over a year, 358 days in those who stayed on varenicline. And basically a year's worth of varenicline tripled your abstinence rate at a year, right? 60% versus this is 19% were able to stay quit, and that's amongst the ones who were successful to begin with. And based on this, the pharmacy director for Mass Health, which is Medicaid in Massachusetts, made the pharmacy benefit for varenicline 1 year for people with schizophrenia. And in working with Gail Dommett for next month's speaker, Medicaid in Maryland has just done that. It took them a little while longer, but they just made it available. So the word's getting out. And data also suggests that extended treatment, or maintenance treatment as we call it, with bupropion or NRT can sustain cessation. And we did another paper where I don't have a slide of it, but we compared people with schizophrenia and bipolar disorder in our paper that was published in JAMA, and people with no psychiatric illness in Serena Tonstad's paper that was published in JAMA. And we basically analyzed the data together, person-level data, where we were able to control for sex and for how much you smoked. And we found that maintenance treatment normalized the relapse curve. So if you stayed on varenicline, Serena's study was only for 6 months, so we only were able to do it for that long. The relapse rate was the same in people with schizophrenia and people with no psychiatric illness. But if you went on placebo, those with the psychiatric illness relapse faster. So that there again, the medicine seems to be especially helpful for people with a psychiatric illness. And studies have shown that those are just the people who are least likely to be given a medicine to help them quit by their doctor. Okay, so we have this idea. If we go to the other side of this slide. Oh no, go back, please. Yeah, so the other side of this slide, this is repeat attempts, okay? So, you know, we have this idea that I certainly learned in residency with Ken and in my fellowship at Mass General, that if you start a medicine and it doesn't really work for somebody, like an antidepressant, well, you need to try a different medicine. But that doesn't seem to be the case for smoking cessation. And that's because I think it takes an average of 5 tries before people can quit for good. And that's the goal, is to quit for good. And this, my colleague, Dr. Gonzalez out in Oregon, did this trial where he enrolled only people who had failed a trial of varenicline. So they had varenicline before, and either they quit and relapsed or they never quit. Those people were enrolled, and they were randomized to get varenicline or placebo, right? So they had varenicline before, and they were basically being enrolled for a repeat attempt. And look at this. These people who previously failed varenicline, 45% were abstinent at the end of this trial for the last month of treatment versus 10% who got placebo plus a behavioral treatment. Now, this trial is not in people with psychiatric illness, but it just goes to show you, just because you've tried once or twice, I tell people when they say, oh, it doesn't work for me, doc, I ask them how many times they've tried. Oh, I've tried 3 times. And I say, well, you're not even average. We're going to try it again. We're going to learn from what you learned before about what helps you quit for the days that you were quit, and we're going to build on that. So next slide, please. So this is why we're here. It's that 15% of the general population smoke tobacco, right? And that hasn't budged, and we need to do better for the general population. But 44% of individuals with bipolar disorder smoke tobacco, and 64% of individuals with schizophrenia smoke. And what that means is, if you look in the middle sort of column here, is that mortality for people with serious mental illness is 3.7-fold higher than the general population. What does that mean? It means that you die 25 years earlier. And if it's schizophrenia, it's over 29 years earlier. That's a generation, right? That's not seeing your grandkids graduate high school. That's huge. And this is fixable, right? Every quit attempt helps you move towards permanent abstinence. So a quit attempt where you quit for a bit and resume smoking is a success, right? Because you've probably learned something, and it means the next time you try, you're more likely to quit. So about 30% of those, 20 to 30% of those who quit are able to sustain that abstinence in that try. But the ones who aren't able to quit in that try are more likely to quit the next time, all right? So I'm going around, trying to get doctors to understand that encouraging and prescribing medications for people with serious mental illness is so worth it and so helpful because, again, tobacco is the only consumer product to kill its users when used as directed, right? That's a pretty crazy statement. Next slide, please. So this is super new, and I want you to bring this to your doctors and any treaters. Please spread the word. The new guidelines. These were published in January 2018, so almost 2 years ago. Is that all smokers should be treated with a medication regardless of readiness to quit. The idea is the treatment will change the readiness to quit, right? So you get, and how this works is, say you give varenicline. Varenicline has nicotinic receptors in the brain, and it binds more tightly than nicotine does. So if you've taken varenicline that day and you smoke, you don't feel much. Like you don't feel so you don't get, it doesn't reinforce. So like you might have learned in psychology, you start to sort of get extinction because you don't get the buzz from it. But it also opens those receptors a little bit so you don't get withdrawal symptoms. And nicotine replacement therapy works sort of similarly. And the analogy is that we don't wait for people with diabetes or high blood pressure to be quote unquote ready to change their diet and exercise before we offer them an effective medication. We try to do both. And we certainly offer the medicine first, and then we work over time on the behavior change, because behavior change is hard, right? Habits are hard to change. So next slide. This is a sort of a schema showing this new guidelines, which is essentially an opt-out. So your if you're a smoker, your doc should recommend a prescription for you at every visit, and make the smoke out, right? So rather than the way most primary care doctors and psychiatrists work now, where they're not going to bring up your smoking cessation unless you do. The new guidelines are they should bring it up, and like if you say no thanks, doc, no, they should bring it up at every visit, right? So that's what this flow chart shows. At the top in purple, offer treatment options, offer behavioral support, and prescribe pharmacotherapy. And first line is varenicline or dual NRT, and second line is bupropion or single NRT. And if the smoker, the person accepts that, that's great. You provide some support, and then you monitor for treatment response. You make sure they're not having side effects, and if they are, you problem solve around how to relieve those. But if they say no thanks, not this time, then you bring it up at every, and then you monitor over time. So next slide, please. So this is the medicines, as I sort of said, but this is table 4 in the new guidelines. So first line treatment or combination nicotine replacement therapy. And we're working on actually start a study where we start that in the hospital, in the psychiatric hospital. And certainly should be done if you're hospitalized for cardiovascular disease. Second line is bupropion or single nicotine replacement therapy. And then down here, this is pretty cool. There are a couple of studies showing that adding nicotine replacement therapy to varenicline improves effectiveness over varenicline alone. And then I've done now 2 studies. George, when he was at Yale, did 2 studies of nicotine replacement therapy with and without bupropion, and found the 2 together were better than bupropion alone. And so success rates are high, the medications are safe and available, and they increase your chance of success sort of 300 to 400%. And I think we've got time. I'm actually going to go through, next slide. This will be available to you. These are all the papers that we've talked from, that I've talked from today. The Eagles trial is this one. This is Antonelli et al. I'm the senior author on this paper. It was published in the not too shabby journal Lancet, and it really did change practice and change the regulatory environment. The retreatment, if you want to look at that, that's the Gonzalez paper. So you know, if at first you don't succeed, try again. So repeat treatment works. This is the JAMA paper I showed. This is the paper where we showed with our JAMA data that. So this is the JAMA trial where we showed maintenance treatment triples abstinence at a year, and then this is the paper that showed that staying on varenicline normalizes the relapse curve for schizophrenia and bipolar disorder to make it the same as smokers with no psychiatric illness whatsoever. And then this is the new consensus guidelines that say that we should treat every smoker regardless of this readiness to quit thing, because the treatment will move the readiness to quit. The next slide. If those weren't enough papers, here's some more. We've got best practices from the Harvard Review of Psychiatry a few years back, and then other papers coming out with illness. This is Jane Hefner's paper that's in the Journal of Affective Disorders for the bipolar subcohort in Eagles. This is the paper that came out in 2019 in Journal of Clinical Psychopharmacology. And then there's a paper coming out just in January in Psychiatric Services, just showing the schizophrenia subcohort from Eagles. I'm going to go to one more slide. Ken, I see you there, but I want to sort of show sort of really why we're here. So the next slide, this is classic data from the Physicians' Health study in the UK. This was published in the British Medical Journal. I think when a long time ago, I think it was before I went to medical school, showing that lo and behold, smoking takes 10 years off your life. And this is in physicians and people with serious mental illness, as I showed you, it's 25 to 29 years, right? And so how you read this is if you're a smoker, you've got a 58% chance to live into age 70. If you've never smoked, you've got an 81% chance of living to age 70. And if you show the next slide, quitting works. So that dotted line is somebody who quit smoking in middle age. They've got like an 80% chance of living to age 70. So they've, it's not an 81% chance, but it's sure better than 58%. This is really the reason we're here, is that smoking kills. And the next slide shows that in 1 million women, that if you smoke like men, you die like men. And again, this is just that same curve flipped on its side. If you're a non-smoker and you're a woman, you've got a 78% chance to live into age 80. If you're a smoker, it's 47%. And next slide, and then this will be the last one, again, to show you that quitting really works. If you quit at age 30, it's like a get-out-of-jail-free card. Your likelihood of early death is no different than a never smoker. But even if you don't quit till you're 50, your all-cause mortality is increased 50% compared to a never smoker, but it's nowhere near somebody who never quits, which is 300 smoker, right? So quit at age 50 have mortality. And I'm going to show you two more slides. Next slide. The next slide is a cover from JAMA. We got our paper in this particular issue of JAMA, which was the 50th anniversary of the time that the Surgeon General made his report that smoking caused cancer in 1964. And 50 years after, we had a paper in this journal, but we couldn't take so much solace because adult smoking had declined by 55% in the general population, but smoking prevalence among people with serious mental illness remained 53%. And that's higher than it was in the general population in the United States in 1964. Next slide. This is an incredible paper that came out in California showing that if you'd ever had a hospitalization in your lifetime for schizophrenia, bipolar disorder, or major depressive disorder, you had a 50% chance of dying from one of the 19 diseases that's causally linked to tobacco use. That's not half the smokers, that's half the people who had a hospitalization. And this is in the statewide data from California. So it's a major deal. And the good news is that next slide, quitting really works. Quitting reduces all of these things. And the next slide, and this will be the last one, quitting actually shows that you have reduction in depression, in anxiety, in stress, and quality of life. And the actual data are, I think, on the next slide, which is a little hard to read, but one more slide. Yeah, so this shows the actual data showing that for every study, the average, which is the dots, the squares and the diamonds, favors improvement in anxiety, depression, mixed anxiety, depression, and stress for quitting versus non-quitting. So quitting smoking, yes, you've got some nicotine withdrawal symptoms in the first couple of weeks, but, it will extend your life, and not only that, it'll make you have less suffering from these psychiatric symptoms within 6 months of quitting. So I'm going to stop there, and I'd love to have questions, and I understand, Ken, you've got some questions?
I've got questions. Dr. Evins, that was a fabulous talk. And I think you make the case quite convincingly that it's never too late to quit, that you can quit, You may have to stay with it and be persistent, but it could change your quality of life and quantity of life, right? That's the message.
That's right.
All right, so the first question, the person wants you to go over varenicline for schizophrenia. Is that your recommendation?
100% yes.
100% yes. So let's develop that. It's the best because it's safe and effective. Is that it?
That's it. It causes no more symptoms than placebo, but it increases your chance of success fivefold.
Got it.
100%.
This is a doctor question. When Chantix first came out, I'm using the trade name because that's the most advertised version that you might have seen on television. There was concerns about suicidality. And I think physicians were quite reluctant to give it to anybody with any mental health vulnerability. That study seems to pretty definitively put that to rest. So I just want to make sure we take that up.
That's right. That was the intent of that study. That was an FDA mandated study. And the reason we got into that, I'll give you a little bit of history. The reason we got into that pickle to begin with is that the FDA allowed the company to conduct all of its safety and efficacy trials in studies that excluded people with psychiatric illness. So a majority of smokers have a psychiatric illness, but yet a medicine was approved without any use in people with psychiatric illness. And so that's just clear discrimination, right? And so what the Eagles study showed is, if you've got a psychiatric illness, you're 3 times more likely to have a psychiatric side effect during the time that you quit smoking than if you don't have a psychiatric illness, right? The rate's 2% if you've got no illness and 6% if you've got a psychotic illness. But there's no difference by whether you're on a placebo or not. I mean, in one of the first studies I ever did of varenicline, the maintenance trial, I was taking care of one of my teachers, Don Goff, one of his, a person who was working with him as their treater was in the study, and this person got more psychotic about 3 weeks into the trial. And Don called me up and said, you need to take her out of the trial. And we said, of course. And we did. And lo and behold, she was on placebo. People have fluctuations in their symptoms. It's part of the challenge of having a mental illness.
Yeah. Okay.
So that's what I think, what those early reports must have been. And they've been laid to rest in study after study after study. And the nice thing about Eagles is it confirms a large body of evidence of smaller trials.
And these slides are available to the listeners and participants today. Dr. Evins, as a full professor at Harvard, this is exhaustively researched. It's very refreshing to see every last study laid out. You make the case quite convincingly. All right, next question. Am I supposed to use the patch or the gum while smoking? I thought that was bad for me.
It's not bad for you, and you can use the patch and the gum while smoking.
Now, why is that? Nicotine isn't bad for you?
Nicotine nicotine will give you a stomach ache if you use too much of it. So if you use the patch and the gum and you still smoke some, you're going to smoke less. Neil Bendowitz, a good friend of mine out at University of California, San Francisco, he's a cardiologist, did a fantastic study where he put 1, 2, and 3 patches on smokers and put a Holter monitor on them, which does a continuous EKG, and he did cortisol, et cetera, and told them to smoke as much as they want. And they smoked less, and there was no problem. This was back in the late 90s. I don't know what it is, who it is that starts these urban myths of how dangerous smoking cessation medications are. I think they're only dangerous to the tobacco industry.
Well, you're crushing these urban myths very nicely. All right, next question. Let's talk a little bit about vaping. And I don't know if this is an urban myth or not, but the question is, you know, I've been told that vaping carries no risk. Why should I quit vaping if it's not going to cause me lung, heart, or cancer risk?
Great question. So the risk of vaping is all relative, right? It's super relative. So I just put a grant in yesterday for a big trial to help kids who've never smoked quit vaping, because vaping is normalizing tobacco use and getting a whole new generation of teenagers addicted to nicotine. Again, kids don't smoke. It's almost rare, but they sure vape because it's cool. Now, if you're a 3-pack-a-day smoker and you switch entirely over to vapes, well, that's less harmful than 3 packs a day of cigarettes. No question. Less harmful.
Okay. I like somebody who knows the answer to every question. It's fun. Question comes in. Right. I am 66 years old. Is it too late for me? And a related question, I've been smoking for 30 years. Is it too late for me?
No. And even if you have emphysema, and you're on oxygen, what quitting smoking will do is not make your emphysema better, but it will make it stop getting worse, right? It will stop the progression. So absolutely not. It is never too late. And I don't have in this slide deck, but they're wonderful graphs. Richard Pito, who's a fabulous, famous epidemiologist, has made these graphs of preservation of lung function out to, and I think his graph stops at age 88 for some reason. But no, it'll preserve your quality of life, and it'll stop the worsening of your lung function. You've probably got some emphysema. Somebody who smoked for 30 years probably got some emphysema. So it'll stop the progression.
I used to play in a pickup basketball league called Never Too Late.
There you go.
And, of course, they could have a smoking cessation sponsor for that, because it sounds like it really is never too late. Here's another sophisticated question. The NAMI audience always asks great questions.
Yep.
What is the current thinking about quitting smoking when you're living with other addiction? And whether that's alcohol, opiates, cocaine, whatever it is it the idea that you're supposed to stop all at once so they don't trigger each other? Or is it more like I'm ready to quit this, but I'm not ready to quit that? Don't make me give up this. I'm willing to give up that. How do you think about that from a behavior change theory?
That's a great question. And really, this talk that I just spoke to, the opt-out approach essentially works for people who have other addictions. And so if I'm treating somebody and they're going on Suboxone for their opioid addiction, or they're going on naltrexone to stop their craving for alcohol, I will also prescribe varenicline. Why not have less craving for tobacco, right? Tobacco triggers addiction essentially makes other substances more addictive. And so if you're smoking and you have a slip, this has been shown for cocaine and heroin so far. If you have a slip, you're more likely to basically have a relapse, and it works in animals as well. If you pre-treat an animal for 2 weeks with nicotine and then expose them to cocaine, that cocaine is more addictive. And the way to say, look, cocaine doesn't need a lot of help being addictive, but it's more addictive, and it doesn't work the other way around. If you pre-treat with cocaine, nicotine is not more addictive. So nicotine has it is amongst the most, nicotine and heroin are the two most addictive substances we have. So try to put them together. Your doc should be prescribing you something, and if they aren't, please educate your doc and ask for it. Yeah.
Does it work the other way? A question is related. I'd like to cut down on my alcohol use. I smoke when I drink. Right? So is the idea that this person would consider doing them both?
So I wrote an editorial in the American Journal of Psychiatry for Stephanie O'Malley at Yale did a study of varenicline for alcohol dependence. And the only good finding she had was varenicline. They reduced their drinking, but they were more likely to quit smoking. So, you know, to try to, again, going with some treatment for quitting smoking is likely to help you. Certainly, you know, you can keep your goals in mind better.
Got it. Person asked a question. My patient's client, so this is a mental health professional, says that smoking helps them manage anxiety and depression. How do you think about that?
Well, I actually have pictures for that too, but I don't have them here. So yes, because every time you smoke, so say first thing in the morning, you're feeling anxious, you smoke, and you feel a reduction in anxiety. Well, that's because anxiety is a withdrawal symptom. And between every cigarette, you go into withdrawal. And so your experience is every time you smoke, you have a reduction in anxiety. That is true. But after you quit, you stop having that spike in anxiety with withdrawal, and so your average anxiety level actually is lower.
People are confusing the symptoms with the cause.
Yep.
So they think smoking is addressing underlying symptoms when in fact it's addressing withdrawal. And this is the idea of nicotine replacement therapy, right?
That's right.
You deal with the withdrawal.
That's right.
That's right.
That's right. That's right. And that's why it's great to be able to say, hey, look, let's try this out. Let's go on for a month. Go on dual NRT or go on varenicline for a month. Don't change your smoking. And then basically they have replacement, and then they can give up the smoking, and they'll see that in that meta-analysis of, I don't know, 40 or some odd papers in the British Medical Journal paper, Taylor et al., actual anxiety symptoms go down, and that's why.
Excellent. That's excellent.
Cool, right?
This person is taking bupropion for depression, has seen no effect on their desire to smoke. Is varenicline or NRT a next logical step? So they happen to be on bupropion, which has a cross-effective effect on smoking cravings, right? But it happens to be an antidepressant, right?
So I would add dual NRT to that, just because I've studied it and I know it's well tolerated. So
what is dual NRT?
Dual, that means the patch plus either the gum or the lozenge. So 2 forms.
Full Monty.
Full Monty, the kitchen sink.
Okay, that's very helpful. Now, we didn't talk at all about therapy or support. We've been talking about the biological cravings, how you have to stay on it for a long time, that it's safe and effective, and that people's symptoms don't get worse. I mean, it's been an amazing educational opportunity for all of us. Psychotherapy, cognitive behavior therapy, support groups, 1-800, quit now. What other non-biological things are in the toolkit?
You bet. And I'll just say, the reason I talked about meds is because people with serious mental illness don't quit without them very well.
Yes. You made that point very clearly, actually.
They don't get them. They don't get them. But yes, we use a group program. We deliver a group because and we get a former quitter to come in with serious mental illness because they've got more street cred than I'll ever have to talk about what work for them. And people, it's supportive. So and people get a little that healthy competitiveness going. So if you can get a group going, we'd be happy to give we've got a manual. We'd be happy to share that. That's not available to everybody. So there's the North American Quit Line. So if you live anywhere from Mexico to Canada, you can call the Quit Line. It's available through all of North America. 1-800 Try to Stop, I think is
Try to Stop. Okay.
Yep. Is helpful, and you know I've never tried to use just a medicine for folks. I feel that.
Got it.
Yeah.
Now, NAMI's big on the peer movement, of course. You're familiar with the Choices program in New Jersey, undoubtedly, where peers coach peers.
Yep.
Is that scalable? How might we think about that? We have this amazing community of peers.
So I'd love to talk about that. We just finished a PCORI trial where we enrolled almost 1,200 smokers in Greater Boston, and the ones who got a community health worker, which could have been a peer, but basically it was a bachelor's trained, non-clinically trained. We put them through the 5-day tobacco treatment specialist program, so they learned something about, they memorized these slides. They doubled their chances of quitting. So a community health worker really was helpful, and partly what that helped people do was to go to their doc and voice what their preference was, help them, with any problems at the pharmacy, getting their meds filled, help get them to group, give them rides to group, but help them stick to their goals. And so I'd love to talk about scaling this.
Good. Other question. How come my psychiatrist doesn't talk to me about my smoking?
It's really messed up. Nobody feels well trained enough. Some places like Massachusetts encourage smoking cessation treatment to be done only by your physical health doctor, not your psychiatric doctor. And the way they encourage that is they only pay for it if it's your physical health doctor. We can't run smoking cessation groups in a psychiatric clinic or addiction clinic and get reimbursed for it. And people feel that they don't have enough training, I think. And so we're trying to change that.
Excellent. I'm old enough to remember when people were given cigarettes to sit through groups with me at the Massachusetts Mental Health Center, our favorite community mental health center. That, of course, was the early 90s. There was a lot of controversy when hospitals went to no smoking.
Yep.
Right? Let's just talk a little bit about that. And at NAMI, we had some complexity because some people felt like when they were in the hospital, they didn't necessarily want to quit smoking. Although in the main, I think we felt that it was the right thing to do. But remember, we're into people's choice. And they're like, that's not when I'm ready to quit. Tell me your observation about how the culture has changed around smoking, where you can smoke, and how that impacts people.
Yeah, so I consulted to the Mass Hospital Association, who were freaking out when JCO was going to.
Yes. They
were really scared that there was going to be more people leaving against medical advice in dangerous ways, more dangerous behavior on the unit, for patients and staff. And in the end, I did a literature review for them and saw that essentially in other places it was a non-issue. As long as you give people something to prevent withdrawal, then they can be comfortable. That way you don't expose others to secondhand smoke. The smoking room in the Lindemann was just deplorable. And secondhand smoke, we've learned a lot about how dangerous that is.
Yes.
So it really respects others' rights, a bit like wearing a mask. It's not just for yourself in COVID time. It's really for the health of your community. So I'm not sure I really answered the spirit of your question.
No, that got to it, right? The idea is it hasn't had a big impact at all, but people do require nicotine replacement strategies so they don't arrive ill and withdrawing.
Yeah, and it's a teachable moment. We're trying to encourage people, inpatient units to offer nicotine replacement therapy that they've been on in the hospital when they go out. People are often entitled to a month of free meds as they walk out the door from a hospitalization, and we found real variability in our fine Massachusetts, Boston hospitals. The Faulkner did a great job of sending people out and hooking them up with smoking cessation resources, and our great Mass General did not. So we're working on that.
Is there any evidence that smoking increases psychiatric symptoms? You mentioned that quitting smoking doesn't increase them. So what about the converse? How does smoking relate to symptoms?
So smoking causes symptoms in between cigarettes when you're in withdrawal.
Right.
You can feel more nervous, more anxious, more stressed. You can feel craving, which is a sense of, it's the opposite of being at ease or equanimity, right, or peace. Smoking can cause tachycardia. It causes a rise in your blood pressure. Smoking, nicotine's a stimulant. I don't know of any credible data that smoking worsens psychotic symptoms, or and just like I wondered when one of the first reasons I started doing this work was to understand whether consider the glutamate hypothesis for negative symptoms, but we people quit smoking if they would have worse negative symptoms, and they did not. But we don't find, the thing that I have seen is and I've published several papers on this, is that nicotine can improve the ability to experience rewarding things that are rewarding. Okay, makes the blue sky bluer, if you will. And that may be the reason, and it improves some cognitive deficits that are seen particularly in people with schizophrenia.
I was going to ask you about cognition, because that was a good question just came through.
Yeah, and so that may be the reason that maintenance treatment is so important for staying off tobacco for people with psychiatric.
Actual nicotine in their bodies without all the toxicities of smoking.
Yeah, nicotine or varenicline. So I tell you, my dad, I'm from North Carolina. I'll give you a little personal. I'm from North Carolina, and my dad smoked 3 packs a day. And in like the year 2000, I think it was, I got him to quit on the gum. He used so much gum, but okay. And you know what? It's 2020, and he's still on the gum.
Still here.
He goes off of it before his physical exam every year or so, and you do not want to be around him for those 2 weeks, and he goes off of it.
Why does he go off of it before his physical exam?
Because he wants to show that he has a negative cotinine in his urine, that he's a non-smoker.
I see.
So he basically detoxes from nicotine so that his urine sample is normal.
I see. Okay.
He shouldn't stop because he can't stay off of it, and he can't taste it. And some people that's the case. So,
yeah, that is the case. It's true for a lot of medicines.
Yeah.
Whether it's antihypertensives or lithium, some people just appear to need these things for decades.
And, the trial with Gail was an 18-month trial that we just finished. So we'll publish that. Maybe we'll try for the New England Journal. We'll see how we do.
Let's talk about the sticky wicket of weight gain.
Yeah.
How real is that? How much risk does that confer? Quitting smoking is great for your health. But if you picked up 5 or 10 pounds, how much does that compare to the benefit of smoking, and how do you prevent picking up 5 or 10 pounds?
Yeah, so we showed, with an exercise program and diet in our study with Gail at Hopkins, that we showed no weight gain, no significant change in weight with abstinence. So if you don't make a real effort, you can gain about 5 pounds when you quit smoking. Now, the famous Walter Willett, I don't know if you know Walter Willett from the Harvard School of Public Health. So he famously said, I think with no data, but with lots of experience, that you'd have to gain 100 pounds to undo the cardiovascular benefit of quitting smoking if you're a pack-a-day smoker. So there's no data, but that's sort of an expert in diet and exercise and cardiovascular risk.
Let's talk a little bit. I think we're going to make this the last question. I have asked you every question from every angle. It's been amazing to talk to you. Let's talk a little bit about the relationship between smoking, stimulating your liver, and what that does to medications. Because I have been able to convince a few people to quit smoking because I told them they could take less antipsychotic. right? So
That's right.
let's just talk about that and make sure we understand that a little better.
Yeah, so smoking, there's like 1,000 toxins in tobacco smoke. It revs up your liver, which is your body's detoxification system. So if you're a smoker, your liver's really active. And so your liver is also what breaks down a lot of the psychiatric meds you might take. Not lithium, not varenicline, but certainly medicines, particularly clozapine, olanzapine. Lots of antidepressants are particularly are metabolized by the particular enzymes that smoking gets rid of. And this is so the first guy who quit smoking back when I was a fellow at the Freedom Trail Clinic was also a UVA grad. Person was on clozapine, 500 milligrams a day, and really annoyed by the drooling that it gave him at night. So it was so he hated that. And I said, look, you can probably reduce, and he smokes a lot, a couple packs a day. You can probably reduce your clozapine dose maybe in half. And he thought that was fantastic. And in fact, he did. He went down to 200. He quit on bupropion, and he went down to 200 milligrams a day of clozapine, and he was a happy camper. And he comes back. He's the person who comes back still to this day, 25 years later. To speak to often our smoking cessation groups the week before the quit date. Yeah.
Fantastic. Fantastic.
And it's another reason to try to quit smoking in the hospital and to try to you go in the hospital because you're having exacerbation of your symptoms. Often you get your meds changed, but you get your meds changed while you're not smoking. And you get sick while you're not smoking. And so really we want, if people are off, they've gone through the worst of it. They've gone through the withdrawal in the hospital. Right. If we keep them off cigarettes on the way out, they're not only more likely to live longer, live better, but the med change that they've just had is more likely to continue to provide symptom relief for them, smoking again and revving up their liver and then being on
fewer side effects because lower doses, right?
Yeah.
Yeah, great. Well, Dr. Evins, I just want to say it's fabulous to see you. It's so impressive to see how much you have learned about this. I mean, it's just amazing, actually. I want to turn it over to Dan Gillison, NAMI CEO, to close out our program.
Thank you, Ken, and Dr. Evins, thank you. You have shared so much information, and just starting with the treatment guidelines and the data and just helping us manage by fact. Your information has just been incredible. And my takeaway is it takes up to 5 times to quit. So it's not the first, the second, or the third. You've got to stay and you've got to continue to do it. So there were some real incredible takeaways. So thank you very much for that. I want to thank our board and our board president, Shirley Holloway, as well as our field alliance leaders. And our staff, and every one of you who have participated in this Ask the Expert. These are very important. We try to make sure there is a good a transfer of information, usable information to you. So we really do appreciate you joining. We also welcome your feedback because we believe in constantly trying to bring the best to you. So if you've got suggestions on topics, or method in terms of how we bring the information to you, let us know. There's a production team that works on these, and they're behind the scenes. And for those of you that love the theater, when you go to the theater, you see the performance, and all of the performers, you don't see the work they do behind the curtains. So with that said, I just want to thank Terry Brister, who leads the production, and Gustavo Guerrera, who helped us on today, Jesse Walthall, Elizabeth Stafford, Christina Bott, Jordan Miller. Really do thank them for their work to make sure, right now we're in an unprecedented time where we're using this pipe to bring information to you. We have grade school students, we have high school students, we have colleges, we have parents, we have employees, workers. All of us are using technology. So it looks seamless to us, but to keep this coming to you during this unprecedented time takes a great deal of work. So we want to thank them, and to Terry Brister and to our Chief Medical Officer, Dr. Ken Duckworth, thank you, because the partnership that you all create and to bring these to us is outstanding. Last thing is a reminder, our next Ask the Expert will be with a very good friend of Dr. Evins that she referenced a couple of times here, Dr. Gail Damit, on December 10th. Physical health, while we haven't titled it yet, it'll really be looking at the physical health impact on mental health. And as you know, the World Health Organization coined the phrase about 21 years ago about there is no physical health without mental health. So we're looking forward to that session on the 10th of December. We wish you all the very best as you close out your week. Thank you for what you do, and thank you for joining us on today. Bye now.
Thank you, Dr. Evans. Take care.